I want to draw your attention to the fact that I'm not only an internist and nephrologist and a honorary member of the Swiss Society of Urology, also a kidney expert of the Swiss Federal Office of Civil Aviation, because my first case with you is an airline pilot. He's born 1960, he's an Airbus captain from Swiss. He had in 1990 his first renal colic immediately after birth of the first child of his wife. So he gave birth of a kidney stone. It was not analyzed. 11 years later, on the takeoff from Zurich to Amsterdam, he got a renal colic. The flight had to be cancelled. The stone passed. It was a 100% calcium oxalate monohydrate. 3 years later, the third stone, prevesical ureteral stone, ureteroscopic stone removal, 100% calcium oxalate monohydrate. At that time, the treating urologist said, the quote is by the referring physician, except for increasing fluid intake, there are no proven dietary measures that can be recommended for preventing further stone episodes in cases of calcium oxalate urolithiasis. Therapeutic realism, my colleagues. The man got a CT abdomen, had 2 small right-sided stones and 1 left-sided stone less than 3 millimeters. The urologist said this could pass spontaneously. ESWL is not indicated. What were the professional consequences for this airline pilot? The patient was still able to fly for Swiss, but only, of course, with a co-pilot. But he had a license to work as a flight expert and pilot trainer was temporarily withdrawn. And this was an additional income that many pilots in Switzerland have. And especially this guy was urgently needed more money because I just bought a new family home. Now, how do stones form? This is a complicated slide. It summarizes many things that I have been working with, especially also in research. In the middle, you have a very normal scenario. All our urines are continuously supersaturated, for instance, with calcium oxalate. While you are sitting here, you are continuously crystallizing 10 million microcrystals per day. These crystals nucleate and grow to a size which during the passage time across the tubuli, 7 minutes, will not reach a size that is dangerous to become a stone. We have basically 2 scenarios whereby stones can occur. The upper panel shows you the free particle size, where you have excessive supersaturation with very rapid crystal aggregation. Larger particles form, are retained in the tubular system and grow out to a kidney stone. The other one, which is sometimes hard to understand, is the fixed particle. The fixed particle came up several years ago and it was very fancy. People think that hypercalciuria will lead to a calcium uptake from tubules, higher calcemia in the vasa recta, where the appetite precipitates occur, and this can be seen on electron microscopy at the basement membrane of Henle's loop. In a way that we don't exactly understand, they accumulate and go up to the papillary epithelium and disrupt, and then you get that, what has been known since 1939, Randall's plaque. And this plaque consists of apatite, calcium phosphate, and is basically the plate whereupon calcium oxalate continuously crystallizes and forms stones. If you do a comprehensive metabolic evaluation, I'm going to talk about that. The purpose is search and identification of risk factors for excessive urinary supersaturation, because that's what is dangerous. Now, when do we do a comprehensive evaluation in stone formers? Basically, in first stone formers, we don't do it routinely. However, there are specific features where we do it. Strong positive family history, chronic inflammatory bowel disease, intestinal bypass surgery, more and more popular, hypercalcemia, bruchite or hydroxyapatite stones, mostly incomplete renal tuber acidosis, multiple or bilateral stones, nephrocalcinosis, carboanhydrase inhibitor treatment, for instance, for glaucoma, anatomic abnormalities such as medullary sponge, kidney, ureter fissures, urinary diversion, and specific situations such as this one is this airline pilot. In all recurrent stone forms, we usually do a comprehensive evaluation. We hand out to our patients a sheet which exactly explains what we are going to do, why we are doing it, and how we are doing it. Important, 2 weeks prior to investigation, we urge the patient to stop medication that could interfere with the chemical composition of the 24-hour urines, if ever possible. And then they come in the first day for a fasting urine, fasting blood draw, and bringing a 24-hour urine. Within 1 week, they collect another 24-hour urine, and they have to measure pH in fasting urines at home themselves. So this is important, this sentence at the beginning of the sheet, while you are on personal free choice diet. We do not do any standard diet. Abnormalities in dietary habits and body metabolism which may have caused your stone disease are evaluated. We give them another sheet for the home measurements of urinary pH after 12 hours of fasting in the morning, a second morning urine. And they get fine-graded test strips provided by us. And in the middle you have the reference field, and if they immerse the strip into the urine, this is going to change the color. And they have to compare the color of the reference field with the colors here indicated on the strip and write down their pH. Now, what is mandatory for the workup? We always require a stone analysis, and in Switzerland we are quite happy. I was working hard for that in the last 20 years, but the urologists always do now a stone analysis and get it to me, the result. In the fasting state, more than 12 hours without eating, we do the anthropometric data, systolic, diastolic blood pressure. We take venous blood, sodium, potassium, ionized calcium, PTH if required because calcium is high, 25-hydroxyvitamin D3, bicarbonate, urea, creatinine. And then uric acid, glucose, cholesterol, all the lipids. Since about 15 years we do that because we have realized that stone patients are internally, nephrologically-wise, sick people, high blood pressure, metabolic syndrome, diabetes, and so on. In the fasting urine, second morning sample, the pH normally is below 5.8. If the dipstick shows leukocytes and nitrite, we do a urine culture and we do microscopy looking for large calcium oxal crystal aggregates and, of course, for cystine crystals. A non-contrast CT if the size and location of residual stones must be known. Sonography often is not accurate enough. It's important to know the stone analysis and relate it to the fasting urine pH. If you have a pure calcium oxalate stone or mainly calcium oxalate stone, we always want to know whether it's a monohydrate or a dihydrate. The monohydrate usually indicates there is hyperoxaluria. The dihydrate is typical for hypercalciuria. If you have apatite or bruchite stones, they usually precipitate at higher urine pH. So this is a signal there could be distal renal tuber acidosis or primary hyperparathyroidism. Uric acid is the other way. Acidic, very acidic urine. Most of our patients have normal uricosurium, but a low pH is the major problem. Magnesium, ammonium phosphide, struvite or carbonate apatite, that's the urologist, that's not our business. We require at least 2 24-hour urine collections with dietary protocols simultaneously written by the patients. The mandatory minimum program is here listed. You see pH, calcium oxalate, uric acid, citrate, volume, and creatinine. These are normal values from ordinary, healthy Swiss people. Might be different in your country. Most of the people copy normal values by the end of 1950s with calciuria much lower than we have in Switzerland, for instance. Important for us, and we do it all the time, is because of the nutrition, sodium, potassium, urea, phosphate, sulfate. What laboratory techniques do we apply? The analysis of the fasting whole venous blood in our stone center is done by an ISTAT point-of-care blood gas analyzer where we get ionized calcium, electrolytes, urea, creatinine, pH, and bicarbonate. In a private central laboratory, we send the blood there for glucose, lipids, phosphate, uric acid, if needed, 25-hydroxyvitamin D and parathyroid hormone. 2-hour fasting urine in the center laboratory is tested by dipstick, microscopy, and pH measured by an ion selective electrode, because it's very important for us for tubular acidosis diagnosis. The analysis of 24-hour urines is done in a private central laboratory. You see all the parameters. Important, if you want to have reasonable oxalate results, the aliquot that is used for oxalate analysis has to be acidified by a HCl to a pH below 2. Sometimes this is forgotten and you get erroneous results. Costs in Switzerland. If you do consultations with me, we do the laboratory analysis, it's in total $1,290 US. If there is a non-contrast CT in addition, it's $1,750, and we have to do the ammonium chloride loading test. It ends up with $2,015 for the whole comprehensive evaluation. Now, we did many years ago 24-hour urine features in recurrent idiopathic stone formers, and we were interested what is the most frequent abnormality that you find is hypercalciuria, the second hyperoxaluria, then low volume hypocitraturia. These were 75 recurrent idiopathic calcium stone formers back in Bern. Now, let me mention a little bit idiopathic hypercalciuria. Idiopathic hypercalciuria is as old as I am, 1953. Fuller Albright, the very well-known endocrinologist, coined the term idiopathic hypercalciuria as a syndrome. Normocalcemia and low serum phosphate, increased urinary calcium excretion, and no obvious secondary causes. Now the question arose pretty soon whether this is a primary intestinal hyperabsorption or a primary leak of calcium. And still many physicians believe in this distinction between absorptive and resorptive hypercalciuria. Lieberman, a smart guy, 1968, said, idiopathic hypercalciuria is a hormonal imbalance. It's a primary disturbance, is neither intestinal hyperabsorption nor urinary hyperexcretion, but both these. I like this a lot, and I tried to make a cartoon to explain that. If you say it is certainly intestinal calcium hyperabsorption, and the patient starts to eat dairy products, so the ionized calcium momentarily will go up because calcium is absorbed in the gastrointestinal tract. The filtered load of calcium will be increased, PTH will be suppressed, the tubular calcium deabsorption will be suppressed too, and you get hypercalciuria. Now the other scenario, tubular leak. If you have a primary tubular leak, your serum calcium will go down, PTH will be upregulated, calcitriol will be upregulated too, and intestinal absorption of calcium is also upregulated. The filter load increases and you get hypercalciuria again. So you cannot clinically distinguish those. Even with all this POC test business, I stopped to do that. Now the question is, if you have hypercalciuria, should you attend a low calcium diet? We have learned that in medical school. Whoever has a calcium oxalate stone with hypercalciuria, avoid dairy products, don't drink calcium-rich mineral waters. This was breakthrough data from Gary Curran in about 30 years now. He did epidemiologic studies in women as well as in men, in thousands of them, and on inclusion to the study, the patients were asked whether they ever had a stone or not. And he was looking over several years how many did newly form a stone in dependence of the calcium intake that they got from dietary protocols. And you see in women as well, in women as well as in men, the trend is clear. The more calcium you eat, the lower the chance of becoming a stone former. This was exactly the opposite what we had learned in medical school. So a low calcium diet increases risk for kidney stones. I did a study back in Bern, calcium intake and bone mineral density. I had, how many? 61 patients with calcium oxalate stone disease, and I took their diet history. And 15 of them had continuously adhered to a low calcium diet as recommended by their physicians, and 46 fortunately did not do that, because those with the low calcium diet had a significantly lower bone mineral density than those with a normal calcium diet. So the conclusion is a low calcium diet not only increases the risk of stones, but also the risk for low bone mass. Mild hyperoxaluria, a very important topic. Hypercalciuria versus hyperoxaluria. What is the more relevant for calcium oxalate particle formation? This is a classic study by Bill Robertson, one of the giants in stone research. He was plotting the volume of calcium oxalate crystals here on the y-axis against the individual concentration of calcium and oxalate in these 24-hour urines of stone patients. And you see there is no significant correlation between the mass of crystals precipitated and the calcium concentration. On the other hand, there is a strongly positive exponential function. The more oxalate increases, even in the so-called normal range, the more particles you get. Why is that? What many people, especially the Americans, who still attend very much to hypercalciuria, have forgotten. Calcium and oxalate crystallize in a 1-to-1 ratio, 1 calcium 2 plus, 1 oxalate 2 minus. But in urine, usually the calcium concentration is about 10 to 20-fold higher than the oxalate concentration. So whenever you start to eat a lot of cheese, your calcium in urine goes up, but nothing happens as long as oxalate stays where it is. However, when you get a little increase in oxalate, then you will get more crystallization and more stones. So even transient increases in oxalate are much more relevant than increases in calcium for the calcium oxalate particle formation in the tubular fluid and in the urine. Now, transient hyperoxaluria is probably the magic word these days. A very strange observation. The majority of the even more and more younger stone patients that I see have always 100% calcium oxalate monohydrate in the stone analysis. So I expect hyperoxaluria. However, about 90% of these stone formers have a normal 24-hour urine oxalate. I get more insight into the pathophysiology of the stone from their dietary protocols than from the 24-hour urines. And I show here a typical case, a hypothetical case, let's say. This is 24 hours. In the morning, the guy consumes cereals with oatmeal. Oxalate will go up. As you see, there is a peak. Then it goes down before noon. When he eats beetroot salad, again, oxalate goes up. Then down again. And in the evening, when watching Champions League on the TV, he is going to eat peanuts and almonds and gets another peak of oxalate. And these transient peaks are probably that what causes the stone, although I do not see 24-hour urine oxalate greatly increased. Where does urinary oxalate come from? About 40% comes from the gastrointestinal absorption. The rest is metabolic, endogenous synthesis or metabolism of amino acids, for instance. The breakdown of vitamin C, high intake of vitamin C, 1,000 and more milligrams per day, you get an increased stone risk. And high intake of fructose, very popular these days, coming from the United States. Fructose is transformed into oxalate. There is always the question whether there could be a reduced colonization with Oxalobacter. There are studies that have proven that, but it's not so far that we can use this Oxalobacter as a treatment. Interesting, fructose in soft drinks, glycoaldehyde, glycolate, glyoxylate, oxalate. That's the pathway. The same with ascorbic acid is here, and hydroxyproline from meat protein also can be transformed into oxalate. So a very big meat eater may have hyperoxaluria, not because it consumes too much oxalate, but because it consumes too much meat. There's a nice study by Dick Johnson and co-workers. They loaded healthy volunteers with fructose, measured oxalate at baseline, gray, and after 200 grams of fructose, red was significantly higher. So fructose is a topic that you have to think about when you see the patients. Now, after professors have for decades said you have to lower calcium intake, they switched and said you have to avoid oxalate. Don't eat spinach. Don't eat rhubarb. That's nonsense. Low oxalate intake is impractical because all plant products, which are basically very healthy things to eat, cereal-based products, chocolates, nuts, berries, black, green, and so on, contain oxalate. So oxalate is basically unavoidable. And this is confirmed by the fact that so far there is not yet any solid evidence from literature that decreasing oxalate intake has a beneficial effect on the recurrence of stones. So what we basically try to do for many years now, the intestinal absorption of oxalate is the only thing that we could influence if we reduce the absorption of oxalate from meals and snacks. How do we do that? Hypothesis: high calcium intake with meals simultaneously will bind the oxalate in the gastrointestinal tract. You get little stones in the gastrointestinal tract, no problem, but the urine oxalate goes down and potentially the risk for stones also. Now, we were testing this hypothesis on healthy people. I was one of them quite many years ago. If we increase tremendously the calcium intake on a crazy diet, a 20-fold oxalate content, spinach cake, rhubarb, all these things, and standardize for calories, fluid, protein, and salt, because this also can affect the urine composition, will reduce the gastrointestinal oxalate absorption and thereby the urinary oxalate. The study subjects were 14 healthy male volunteers, 23 to 44 years, never had formed kidney stones so far, and no family history of nephrolithiasis, normal urine function. The study protocol consisted of 3 collections of 24-hour urines, individual free choice diet, standardized diet with high oxalate and normal calcium, 1200 milligrams a day, and standardized diet plus very high calcium intake. So high oxalate plus more than 3.5 grams of calcium. Here you see what happened. You see here the calcium per 24-hour in the urines, basal white, on the high oxalate normal calcium red, and on the high calcium, high oxalate blue, it was still normal but significantly elevated. Of course, you had more calcium ingested. Here is the oxalate. Basal, normal, high oxalate, normal calcium, sky high. We had oxalate more millimole per 24-hour, like in primary hyperoxaluria. If you did increase the calcium to 3.8 milligrams per day, it was normal again. And what we saw in the microscope, healthy people never formed stones. After 24 hours, microstones, 80 micrometers, with the high oxalate normal calcium. If you did the same again, normal little calcium oxalate crystals in the urine. There is, of course, the best study on diet is the one from Borghi. He did 2 different dietary interventions in male patients with calcium oxalate nephrolithiasis over 5 years. The low calcium, no dairy product, the classical diet, versus a normal calcium, low protein, low salt with 1200 milligrams of calcium. And the relative risk of a recurrence was not 0, but it was 51% less with the high calcium diet. And over the whole study period, oxalate, which is in green in the normal calcium diet and low protein diet, was lower than the red ones, which was the low calcium diet. So he was able to continuously reduce the oxalic excretion. We turn back to our airline pilot. The stone analysis tells you the pathophysiology of the stone formation, so read it carefully. Calcium oxalate, is it monohydrate? Is it dihydrate? He had monohydrate, so hyperoxaluria must be present. This is his 24-hour urine chemistry. You see in parentheses the normal values. He had a decent urine volume, had a very high salt consumption, an excessively high oxalate, and quite a lot of urea, which indicates protein consumption. The fasting urine pH was 5.19. This is called undue urine acidity, so also a risk for uric acid stone formation. His salt intake was too high, and protein intake was also too high. Now, the history of the patient is very important. And I take all the histories myself. If the dietitian does it take, it's probably different. So you have to really listen to the patient. The patient's wife was also a stone former, and she had been recommended a low calcium diet. The patient's diet history: a low calcium intake, 5 yogurts per week, 3 times cheese per week, no milk. So he was on a low calcium diet, on an average 400 milligrams per day or even less. But as an airline pilot on long-haul flights, he was staying in hotels and admitted to ingest kilos of peanuts while staying on long-haul flights. So very rich in oxalate. So he had oxalate excess and hyperoxaluria. Now, low urine volume was the next following admonition that we found in our patients. Drink more, higher urine volume. It's always indicated irrespective of the stone analysis. The question is only how much. This is also the same study of Gary Curran, epidemiologic study from the United States. And you see the higher urine volume, the lower the chance of becoming a stone former. However, it has to be more than 2.5 liters to really significantly reduce the stone risk. Hydration, what happens with the renal papillary density? Very interesting study for my Italian colleagues. They took stone formers and looked at crystalline deposit in renal parenchyma with papillary densities on CT scans. 25 recurrent idiopathic calcium stone formers, CT scan before stone removal. The papillary density was recorded in Hounsfield units. At least 2 liters of low sodium bicarbonate rich mineral water were administered, and after 3 to 4 months, they checked the maintenance of adherence, and after 22 plus minus 5 months did a second CT scan and looked at papillary density. And very interestingly, after hydration, right and left kidneys were significantly lower, less dense than before hydration. So they concluded an increased fluid intake is likely to modify the concentration of lithogenic salts in the renal tissue. Now, urine volume. Many patients tell me, oh, I have been told to drink more. The question is how much? I always tell my patients the following. When you sit here, as you do right now, within 24 hours, there will be imperceptible loss of fluid over mucous membranes, respiration, and skin. About 3/4 of a liter per day is gone. Then you start to transpire, visible loss of fluid, physical activity, emotional stress, ambient temperature, very important here. So as a rule of thumb, in Switzerland, to my patients, I say at least 1 day of fluid is already gone before you even start to drink. So drink at least 3 liters in order to pass at least 2 liters of urine per day. In hot climates as here or in cystine stone formers, I would say 4 to 6 liters per day is okay. It can be trained. There is like a hydrostat here, and if you get used to drink more, it will be automatically work. Low urinary citrate and hypositraturia. I show you a second case. Pretty interesting. A woman born 1964, severely recurrent brushite stones. Always a problem for more than 20 years. 13 ESWL, 1 open surgery, 1 laparoscopic surgery. Metabolic evaluation showed hypercalciuria and low citraturia. She also had osteopenia. Her urine pH always was 6 to 7.5 in her chart, but nobody had noticed that. So my question, what is the likely diagnosis and how should we proceed? Who wants to tell me the diagnosis? Yes? Very good. Okay, hypositraturia and kidney stone formers, how often do we see that? It depends on the population and on the people who investigate the patients. 24% in Brazil, 24% in Germany, 29% in our male recurrent stone formers back in Bern, 32% in Spain. When we looked at patients with incomplete distal RTA, it was 63%, and in Thailand, 70%. I don't know why, but it was very high. Now, what is urinary citrate? What is its importance? It is the most abundant anion in human urine. It is most important and cheapest marker of intracellular acid-base balance. If the acidity of renal cells goes down, for instance, by dietary maneuvers, citraturia will go up. It is a chelator. It is able to form soluble complexes with calcium, thereby reducing the urinary supersaturation of calcium oxalate as well as phosphate. It is a direct crystallization inhibitor of calcium oxalate and phosphate growth and aggregation. It is an alkalinizer because citrate is intrahepatically transformed to bicarbonate, increases urine pH, increases solubility of uric acid and cysteine. So in every 24-hour urine collection stone, citrate must be measured. It correlates very well with dietary alkali. Old data by Charlie Puck and co-workers, citrate on the y-axis and the gastrointestinal absorption of alkali on the x-axis is a linear correlation. The more alkali you eat, the higher citraturia becomes. On the other hand, it's dependent on the acid load. If you have intracellular acidosis due to an increased dietary acid load, for instance, you will reabsorb more citrate in the proximal tubule and excrete less in the urine. On the other hand, if you have intracellular alkalosis, diet high in rich in vegetables and so on, it will be more citrate in your urine. These are the causes of decreased urinary citrate excretion. So systemic metabolic acidosis, for instance, in CKD, don't measure citrates, it's low anyway. Incomplete distal renal tubular acidosis, as in our patient, it's low. Dietary acid load, especially meat protein, reduce citrate excretion. Dietary salt loading, reduce renin, angiotensin II, and the activity of the luminal sodium hydrogen antiporter, thereby the intracellular hydrogen concentration goes up, low citrate. Malabsorption syndromes with chronic diarrhea, very important bariatric surgery, I come to that later, but also morbus Crohn and colitis ulcerosa. Carboanhydrate inhibitors, for instance acetazolamide, used for glaucoma, they produce a mixed proximal and distal renal tubular acidosis. And potassium depletion, thiazides, also reduce citraturia, which is bad. I just want to do a comment on distal renal tubular acidosis. This is the tubular lumen on the left and interstitium on the right, and we are in the intercalated cell at the end of the renal tubule, and there is a hydrogen ATPase which transport hydrogen ions out into the urine, where it combines with NH3 ammonium to NH4+, If you do not do that, you retain the hydrogen ions and you get the intracellular acidosis and you get less bicarbonate coming back to the body. The major causes are either primary, idiopathic or familial, or secondary autoimmune disorders, drugs, hypercalciuric conditions, hyperparathyroidism, for instance. If you do surgery in hyperparathyroid patients, tubular acidosis can be reversed. I have seen this. Medullary sponge kidney quite often is also associated with this disease. The complete form, which means that you are permanently acidemic, so have a low pH also in the blood and a high pH in the urine, is very rare. It produces hypercalciuria because there is bone dissolution and reduced tubular reabsorption in acidosis, as well as hypocitraturia of the mechanism that I have shown. Very common in my patients, every fourth woman with stones or osteoporosis and every seventh man with osteoporosis or stones has this disease. Never acidemic, but high fasting urine pH and the same hypercalciuria, hypocitraturia. Both forms predisposed to calcium stone formation, appetite bruchite, nephrosis and low bone mass. We did a matched pair analysis in our study that we published 2 years ago of patients with idiopathic calcium stones and those with incomplete distal renal RTA. The RTA patients had 1.9 times often hypercalciuria, 1.4 times often low citrate, 1.5 times more stones per year of disease, 1.4 times more intrarenal calcification, so nephrocalcinosis, and a history of low bone mass was clearly more frequent in those patients. Now, how do we diagnose this? There is the classic ammonium chloride loading test by Wrong and Davis. Everybody is going to vomit. So I changed that many years ago in a one-day test with half the dose, divided in 3 doses before main meals, and the next day you come fasting to our practice. The liver transforms the ammonium chloride into ammonia and HCl acid, and the normal pattern is that you then are able to lower urine pH below 5.45 and venous bicarbonate stays above 20.5. We did that in the woman, and she lowered urine pH to 5.56 with a normal venous bicarbonate. So by definition, this was incomplete distal renal tubular acidosis. How you treat that? 1,200 milligrams of calcium because of the bones, no low calcium diet, alkali citrate in a sufficient amount to neutralize the retained hydrogen ions, and a high fluid intake. For 3 years, I didn't hear anything from her, so new bruchite stones. Then the patient was afraid of bone loss. So after 3 years, immediately a new stone, and because she was married to a pharmacist, which is very dangerous, her husband recommended, you are going into menopause, you need more calcium. I already had recommended her 1,200 milligrams. He gave another 1.5 grams a day, so she ingested calcium up to 3 grams per day. Now what happens? This is with true molar values, urinary oxalate and urinary calcium in case of high calcium intake, pink, normal calcium intake, blue, and low calcium intake, gray. And you see the lower the calcium intake, the higher the oxalate. You understand that because I was explaining that. Now, how is it with phosphate? It's exactly the opposite way, because you have always very high phosphate, protein metabolism, bone metabolism. So when you increase calcium, the red curve, then you will have excess of phosphate to crystallize. And if you do that, you will get calcium phosphate stones. So in tubular acidosis, you have to tell the patient very precisely to take enough calcium, 1,200 milligrams, but not more. Otherwise, you might run into calcium phosphate stones because the pH is high. and phosphate likes to precipitate at high pH. Successful treatment in incomplete renal tubular acidosis is a long-term alkali treatment, which is an adherence problem. I admit that, frankly. You have to increase the buffer capacity to neutralize the retained hydrogen ions. We recommended our patients 40 to 60 milligrams milliequivalent per day, and I did phone calls after 4 to 15 years to recall the patients, and I found that 30 of the incomplete tubular acidosis patients had adhered to my recommendation and 19 not. There was a significant difference in the clinical stone events, and if you look at stone events per years of follow-up, it was 5.5 times higher in the non-adherent patients. We get back to the airline pilot. I'm here sitting in the cockpit of an Airbus, flying with him from Zurich to Malaga. He was inviting me because I had to see how pilots work, because I'm responsible for the pilots. He was stone-free for 13 years, fully apt to fly. These are the Swiss Alps. He was on high fluid intake, increased calcium intake simultaneously with ingestion, and no abuse of oxalate-rich products, and small evening dose of potassium citrate for increasing the inhibition. Now what happened? Early retirement, 2018. He went into real estate business, had a very high income, lot of administrative work, a severe marital crisis, and finally a very expensive divorce, psychosocial stress, altered drinking and eating habits, and a terrible stone colic and hydronephrosis with a left-sided prevesical stone and pelvic stone. He had to undergo URS and stone removal, again 100% calcium oxalate monohydrate. Let's take a minute to look at something which is also very important: stress. Stressful life events and nephrolithiasis. This is a study, 200 stone patients versus 200 age and sex match controls, screened for 11 stress categories: health, employment, personal finances, housing, marriage, and so on. And what you see here, all the stress factors are more frequent in stone formers versus controls. And that's my personal experience too. Stone formers are many times very strict people who want to be very precise and are rather quickly stressed. That this goes along many times with periods of no drinking, through 4 hours, telephone calls, computer, the chief coming in, and that's stress for the patients. And you have to address that too in your clinic. Stone formers are more prone to psychosocial stress than healthy controls. Now, the preventive treatment of calcium oxalate stone disease, dietary intervention, very important. There was an evidence-based meta-analysis by Fink in 2013, so more than 10 years ago, and they came up with the conclusion: significantly reduced stone recurrent rates occur with high fluid intake, obvious. Reduced soft drink consumption, I told you already. Extensive biological evaluation plus individually tailored dietary recommendations, whatever that means. And multi-component balanced mixed diet with calcium intake of 1200 milligrams a day. When we looked at our efforts in dietary recommendations back in Bern, we were measuring calcium oxalate supersaturation in urines before and after dietary recommendation, and we were looking after 3 to 5 months on the delta. The delta of the calcium oxalate supersaturation was positively correlated with the delta in oxalate. So oxalate makes stones, of course. It was negatively correlated with pH. So the higher pH, the lower supersaturation, the higher volume, the lower supersaturation, and the higher alkali intake, the lower supersaturation. It's also obvious. What the Americans don't like, but it's true. Calcium was not correlated with the change in urinary supersaturation. Calcium oxalate. So I thought, if you want to reduce the supersaturation and thereby the stone risk, what do we have to do with our patients? we have to push a lot the urine volume. We have to reduce the promotion by reducing urinary oxalate and increase the inhibition by alkali intake with higher urine citrate and higher urine pH. What did we do? We took 75 idiopathic calcium stone formers and told them to drink at least 3 liters, so they get a urine volume more than 2 liters per day. The promotion of calcium oxalate crystallization can be reduced if you significantly increase calcium intake simultaneously with meal snacks and avoid oxalate excesses. There was no systematic oxalate restriction, just avoid abuse. Inhibition of crystallization, more alkali. So we told them meat protein once a day and not more. Alkali at least 3 servings per day. The WHO recommends 5, but I don't know of anybody in Switzerland who manages that. So 3 would be sufficient. Then we had 2 24-hour urines at baseline, then the dietary recommendation as just presented, and after 3 to 5 months, another 24-hour urine. Now the method of measuring relative supersaturation in routine, almost never done. Equal2 is a sophisticated computer program. I was using it once for a study, and much more practical is the Tiselius index. Hans-Göran Tiselius is a famous Swedish urologist who developed this formula, and it's easier to apply if you want to do that in clinic. I don't do it, I only use it for scientific purposes. It correlates perfectly with the Equal program for calcium oxalate supersaturation. So what we recommended the patients is this common sense diet. The principle, the better, and I do that with all my patients. Drink more, at least 3 liters per day. We were talking about that. The urine color should be watery yellow over 24 hours. Drink before going to sleep. You should have 1 to 2 nightly micturitions. Acid meat protein, never twice a day, 5 to 7 times per week, okay. Many patients still are on a low calcium diet, so you have to instruct them, target 1200 milligrams from calcium-rich mineral waters and from dairy products. Oxalate, no abuse, otherwise everything permitted, always combined with calcium. Alkali, 3 servings per day. This is the sheet of paper that we, in different form, give to our patients. I changed that for you. What is the content of water and mineral water? Seawater, which you have widely available, 400 milligrams per liter, but you desaltify it and it's 50. Tap water in Switzerland, 50 to 100 milligrams per liter. In the internet, Abrei mineral water is called a calcium-rich mineral water, very good for your bones. I was reading that yesterday. So 25 milligrams per liter is tap water. In Switzerland, we have very good and very bad mineral waters. The range is from 12 to 579 milligrams per liter. The dairy products, you see here, yogurt, kefir, Laban, it's all similar. The richest cheese, calcium-richest cheese is Parmesan. Emmental is also fine, Edam is okay, and the brie, the soft cheeses are rather low in calcium. Many patients, especially women, tell me all the time, there are vegetables with a lot of calcium, especially broccoli. It's there, but it's not a lot. How much calcium is required to crystallize oxalate in the GI tract in a patient? The calcium molecular weight is 40. The oxalate is 88, so it's 2.2 times the calcium. This is a famous product that everybody is consuming these days, cashew nuts. They have 260 milligrams per 100 gram, and 100 gram you easily eat. So 100 gram cashew nuts with 260 milligrams of oxalate require 572 milligrams of calcium, which is almost 500 grams of yogurt, simultaneously ingested to completely bind, crystallize the ingested oxalate in the gastrointestinal tract and block the absorption. Now in our study, what were the results before DA, dietary advice, and after DA? Significant increase in volume, unchanged pH, and so on. Significant increase in calcium because recommended high calcium. And for me, high calcium is the index that oxalate is blocked. And oxalate was significantly lower. And uric acid as a marker of protein intake significantly lower. Citrate, borderline higher. And magnesium also significantly higher than before. When we then did the calculations of urine supersaturation by the Tiselius formula, we were able to reduce the supersaturation in the whole group by 21.5%. There were some who did not really reduce it and some who even did reduce it more. Now question, what is this? This is a renal biopsy. Would somebody like to give me a hint what this could be? This is my case 3. A 60-year-old man was newly admitted to hemodialysis in Bern, and the nephrologist, she said, I don't understand why this guy is uremic. And then it turned out that he had had a distal Roux-en-Y bypass 8 years before, and she did a biopsy, and what you see here, all this blue stuff, is calcium oxalate. It's a secondary oxalate nephropathy after Roux-en-Y bypass. And I take this to talk a little bit about obesity and calcium oxalate kidney stones. There are 2 stones associated with obesity. I talk now on calcium oxalate. I will do it later on uric acid. You know that there are several methods how to do bariatric surgery, and there is a big survey from Sweden, and they were showing that the hazard ratio for becoming a stone former was 6 times higher with sleeve gastrectomy and Roux-en-Y bypass, and even 10-fold higher with biliopancreatic diversion. I got a woman from Bern referred to me several years ago. She was very obese, BMI 51. It was a farmer's woman, and Marceau bypass, a biliopancreatic diversion with a common channel of only 80 centimeters. So the majority of small intestine was bypassed. The sequelae, the body weight was by almost 50% reduced, great success, but she got chronic diarrhea up to 8 thin stools per day. 3 kidney stones passed spontaneously, once ESWL, once retrograde stone removal, an obstructing urethral stone with urosepsis, and on the CT scan, nephrocalcinosis present. The stone analysis, 80% oxalate monohydrate and 20 dihydrate. Her urine chemistry, 2016, 2 urines within 1 week, low volume, excessively high oxalic acid, very low citrate. The diet history, she not only had the bypass, but she also liked oxalate-rich products, chocolate, nuts, and olives. Low calcium intake with meals. She was drinking tap water because it's cheaper than mineral water. Calculations, salt consumption was slightly elevated, and the protein consumption was also too high for her normal weight. Now, what about hyperoxaluria in these patients? Again, the study by Robertson. In this case, we had not anymore a 20-to-1 ratio of calcium to oxalate, but a 3-to-1. And her oxalic acid concentrations were in the very high range where it must crystallize more. What are the mechanisms of hyperoxaluria? Steatorrhea. The calcium is bound to malabsorbed fatty acids and forms so-called calcium soaps. So there is reduced intestinal binding of oxalate by calcium and an increased calcium oxalate absorption. Malabsorbed bile acids. The bile acids are terrible because they increase the permeability of the gastrointestinal tract, and you absorb automatically more oxalate. And it has been said that there is intestine colonization with Oxalobacter formigenes is reduced, more free oxalate available, more absorbed. All that together, increased plasma oxalate, hyperoxaluria. This is a nice study from Brazil. They had 10 morbidly obese patients before and 12 months after malabsorptive bariatric surgery. The BMI went down from 43 to 29. And they gave them an oral spinach juice with 375 milligrams of oxalate after an overnight fasting. And they did urine collections over 6 hours. And you see on the left side, the oxalate concentrations or oxalate over creatinine ratio was significantly higher post-bariatric surgery. And if you did the area under the curve, that was highly significantly more oxalate coming out over 6 hours. Now, furthermore, this woman had a frank metabolic acidosis due to the continuous loss of alkali by the severe diarrhea and thereby a very low citrate. So hypocitraturia was explained by diarrhea and the high protein intake. Now, the chronic diarrhea, chronic bicarbonate losses, renal citrate reabsorption, hypocitraturia. The volume, many patients with frank, severe diarrhea don't dare to drink because they are afraid that they will have more diarrhea if they drink a lot. That is probably one of the reasons why urine volume was low. Now, what I did, I recommended her to significantly increase fluid intake, a high calcium with meal snacks, but not 1,200 milligrams, but up to 8 grams sometimes in these patients. 1,000 milligram supplements plus mineral water with main meals, 500 to 1,000 milligrams with snacks, calcium-rich mineral water with high calcium content. So you have more calcium available to intestinally bind the oxalate. I gave her potassium citrate tablets, and the venous bicarbonate rose nicely to 20.7, still too low, but much better. And I told her to reduce protein intake. Now what happened? Urine volume significantly increased, but we didn't manage hyperoxaluria and hypocitraturia in this intermittent test 3 months later. Now, if you go to the very old literature, where Linwood Smith, a giant in oxaluria, he tested patients, 4 cases, with short bowel syndrome after distal ileum resection, and they had very high oxalic acid, up to 1.5 millimoles per day. And he gave them terrible doses of the bile acid binder cholestyramine, 4 times 4 grams, but he had a significant success, oxaluria normalized. I didn't dare to give that much, but I gave her 4 grams per day and said she should continue with the rest of the measures. Intermittently, she had got chronic myeloid leukemia. She was treated and still had 2 creamy stools per day. When she came to me 2 years ago, she had a very good urine volume, a normal, high normal oxalate, but still a low citrate. Since then, I haven't heard anything from her, but I think the diarrhea is still a problem. Now, at the end, the preventive treatment for calcium oxalate stone disease medication. Most of the patients say, oh, do I have to change my diet? I don't like that. Is there not a pill for that? This is also the same study from Fink and co-workers 10 years ago, meta-analysis of medication, thiazides. Thiazides, very small studies, a total of about 300 patients studied, and you see that there was here a 48 reduction in stone recurrences with thiazides. However, the mechanism is not clear. It's not hypercalciuria. Even if one of the first important papers by Ettinger, he stated himself, the lowering of calcium excretion in urine did not explain the effect. Citrate, also not many studies with low caseload, but a 75% reduction in stone recurrence. The mechanism is known. That's why I like citrate. I know what I'm doing. Now the Americans, they still very much believe in hydrochlorothiazide. And that's why we in Switzerland, especially Professor Danny Fuster in Bern, decided to do a real good trial because it has never been done before. And he did a multi-center, 8 centers in Switzerland, placebo-controlled trial. Hydrochlorothiazide has originally been introduced as a stone treatment in the dose of 50 milligrams. Because we treat so many hypertensive patients with 12.5 and 25, we also treat stone patients sometimes with low doses. So what he did, he randomized into placebo 12.5, 25 and 50 milligrams of hydrochlorothiazide over 3 to 4 years. I was not a co-author but a senior advisor because I had told him it will not work, and that's exactly what happened. What came out? The primary endpoint was not different irrespective of the dose of hydrochlorothiazide or of a placebo. So all hydrochlorothiazide was non-significant versus placebo, but the adverse effects were significantly more often present in patients with hydrochlorothiazide, diabetes mellitus, hypokalemia, gout, skin allergy, more than 150% increase in plasma creatinine. My personal conclusion, I don't use thiazide. This has been my policy for many years. What are the adverse effects? Some of them came up in the study. There is also increased lipids, gastrointestinal complaints, drowsiness, dizziness, decreased libido, and impotence. That's why many men don't like the thiazides. The adverse effects of alkali citrate are bloating, irritation, diarrhea, clinically in about 30%. In studies, you see 26% with potassium magnesium citrate, sodium potassium citrate, 20%. Potassium effervescence that we were using earlier on in Switzerland, there are no data. Potassium citrate, Urocit, that's what I'm using. In the studies, 9.3 to 17%, but that's probably underestimated. Skin, very rarely, is a pruritus or rash or urticaria. Very important, what occurs when you prescribe drugs. This is a study from Tel Aviv over 6 years, telephone survey and monitoring of drug sales, 356 patients, 199 on alkali citrate, 149 on hydrochlorothiazide. The long-term adherence rate was higher in hydrochlorothiazide than in alkali citrate. The main reasons for non-adherence in the citrate group was the number of pills, and 10% only adverse effects, and in hydrochlorothiazide it was exactly the opposite. Many more people had adverse drug effects, was significant versus alkali. The poor adherence occurred in younger, otherwise more healthy patients. My summary and my conclusions. A comprehensive evaluation is indicated in all recurrent stone formers as well as in those with additional systemic pathologies and specific conditions I was talking about. A comprehensive metabolic evaluation always should include a careful patient history, not only on the stones, but the whole medical spectrum. Anthropometric data, stone analysis, fasting venous blood, fasting second morning urine, 2 24-hour urine collections and follow-up urine collection after 3 months on recommended treatment. Low urine volume, low calcium intake, and reciprocal oxalate hyperabsorption and hyperoxaluria, as well as low urinary citrate, are the most common urinary risk factors for calcium oxalate stone formation. As changes in urine calcium concentration do not correlate with the calculated supersaturation, hypercalciuria is much less important than hyperoxaluria for calcium oxalate particle formation in urine. Distal RTA, mostly incomplete, is highly prevalent, at least in Europe, and associated with low citrate, calcium stone formation, especially apatite bruchite, nephrocalcinosis, and low bone mass. Alkali treatment is mandatory to avoid recurrences, pronounced nephrocalcinosis, and progressive loss of bone mass. High fluid intake in order to reach urine volumes of more than 2 liters a day is the most important measure to reduce urinary supersaturation. Recommending low consumption of oxalate-containing food is useless, as almost all foodstuffs contain oxalate, and total avoidance could induce nutritional deficiencies. A total calcium intake of 1200 milligrams a day ingested simultaneously with all meals and snacks is the best measure to reduce gastrointestinal absorption of oxalate and thereby often transient hyperoxalurias. A sufficient intake of alkali, at least 3 servings of vegetable salad and fruit per day, and not more than once a day animal protein, meat, fish, poultry, equilibrate acid-base balance of the body and raise urinary excretion of citrate. For medical therapy, alkali citrate or other alkali preparations are to prefer over hydrochlorothiazide because their mechanism of action is known and they reduce stone recurrence rates to a greater extent than hydrochlorothiazide, which, under strict monitoring in a placebo-controlled randomized trial, has no significant effect on stone recurrences. And this is the end of my first talk. I thank you for your attention.
So welcome back. I think we have to start our next session. Let me draw your attention that this talk was sponsored by ATC, and it's in conjunction between the KNA, Kuwait Nephrology Association, and KUA, Kuwait Urology Association. So, Dr. Hess.
Let's get back to work. I proposed as a second talk to talk about the non-calcium stone formers. This will be less time consuming. So I'll talk about uric acid stones, infection stones, cystine stones, and a little bit about drug-induced stones, not about 2,8-dihydroxyadenine stones and xanthine stones. Now, if you look at the stones that we see, stone patients, we have 85% calcium stones, mainly calcium oxalate, a little bit calcium oxalate mixed with uric acid, 10% uric acid, and few infection and cystine stones. Now, the impact of diet is very high in calcium oxalate stones, is not very high in uric acid stones, and is almost of no impact with infection and cystine stones. Uric acid stones, it's all about pH. Uric acid stones, 8 to 10% of all kidney stones in the Western Hemisphere at least. There is an association with hyperuricemia, gout, and metabolic syndrome. The main urinary risk factors are a low urine pH. The Americans call that undue urine acidity. This is the most important feature of uric acid stones. Hyperuricuria. I think it's very often the case in the United States because they're overeaters of meat. In Switzerland, I do not see many hyperuric patients with uric acid stones, but I see those with very low urine pH. Uric acid is a weak acid, has a pK value of 5.35. Its solubility is 0.45 millimoles per liter. Imagine we excrete 3 to 4 to 5 millimoles per day, and it's that low solubility, it must crystallize even at normal excretions per 24 hours. If we increase the pH, then it slowly crystallizes as sodium urate, which is to prefer. This is the important sheet that I was already showing. In these patients, it is very important that we get enough pH measurements from the patient as well as in our unit to clearly define low urine acidity, high urine acidity. So the stone analysis we always require in the fasting state is exactly the same as we did in the calcium stone formers. However, these patients are more than calcium oxalate stone patients, metabolically sick, internal medicine nephrology patients. So here you really need glucose, cholesterol, and so on also to measure. The fasting urine, I already was alluding to that. We look, of course, whether there are uric acid crystals in the microscope, and EuroCT only if you have to know whether there are residual stones or not. This is basically the same as I was already showing to you. We do the same measurements basically, except that we have a high, pH has a high impact. And gout and kidney stones is epidemiology. The history of kidney stones, 49,000 men cross-sectional, multivariate adjusted relative risk for kidney stones, clearly higher in those with gout. Incident stones in 400,000 patients, clearly higher in gout versus non-gout. BMIs by stone types. This is a study from London originally. The BMI under 25, 25 to 30 and higher. You see the yellow columns, calcium oxalate, there's no difference. You see, however, that calcium phosphate stones, for whatever reasons, with increasing BMI are less frequent. The opposite is uric acid stones. The fatter people are, the more uric acid stones they form. So we are going to talk about obesity and kidney stones, chapter 2, uric acid stones. Obesity, very low urine pH. Charlie Puck and Fred Coe, I was working with him for 2 years. They are the big giants in kidney stone disease in the United States. And they merged their database and got about 5,000 patients and plotted the urine pH versus the body weight in 6 tiles. And the heavier you become, the lower your urine pH is. This is a nomogram of Fred Coe that he did years ago, 1980. Here you see on the left, on the y-axis, the undissociated uric acid, which is highly insoluble, 0.54 millimoles per liter. This is the dashed line here. And what happens with total uric acid and undissociated uric acid, depending on the pH. So if we say a patient has 3.0 millimoles uric acid per liter, and his pH is 5, he will excessively be over the solubility threshold. However, when you increase the pH to 6.5, he will dissolve the undissociated uric acid and the risk of stones is lower. Now, the people in Dallas were quite smart and look a little bit in more detail in the connection between uric acid stones and metabolic disease. They saw that if you take controls and uric acid stone formers have significantly higher triglycerides, lower HDL cholesterol, and higher fasting glucose. If you look at their 24-hour urine pH, significantly lower in uric acid stone formers. If you look at the at the urinary NH4 plus, or net acid excretion, you see that there is lower NH4 plus, so less ammonium coming out in the urine in these uric acid stone forms. Now the question is this ratio here due to a decrease of the numerator, NH4 plus, or an increase in the denominator? First hypothesis, undue urine acidity is due to a reduced in NH4 plus secretion by the kidneys. Now we're going to look into the physiologic insulin effects in the proximal tubule. Insulin stimulates the tubular sodium hydrogen exchanger, thereby increases sodium absorption and hydrogen ion secretion and fluid absorption. More important for our discussion, the ammonium production from L-glutamine is increased in the kidney tubule cells with increased ammonium secretion under the influence of insulin. These obese people with diabetes or prediabetes could have, that was the hypothesis, a renal tubular insulin resistance. So they were looking into that, and the hypothesis, if you get less ammoniogenesis, less ammonium excretion, more unbound urines in the tubular fluid, reduced urine pH, uric acid stones, insulin resistance at the renal level. Insulin sensitivity is linearly correlated with abdominal central fat. So the fatter you are, the less insulin sensitive you are. Or on the other hand, the fatter you are, the more insulin resistant you are. And that's exactly what they found. They did a hyperinsulinic clamp study in patients with uric acid stones, the black dots, and controls, the circles. And they found that the black dots, as you see here, are more at the lower pH range and at the higher insulin resistance level. So the conclusion was uric acid stone formers have a lower urine pH and are more insulin resistant. So this fact could be undue urine acidity, may be a renal manifestation of the metabolic syndrome. That was the first part of the story. Now the second one, more recently, it could be that uric acid stone formers per se have a higher net acid excretion, probably even independent of diet. So what they did, they took 38 idiopathic uric acid stone formers, females and males, and sex and BMI matched and age matched controls on a 3-day outpatient stabilization phase and then a 2-day inpatient stabilization and evaluation phase. Throughout the study, the people got a dietitian-formulated metabolic diet, very precisely done, and they did 24-hour urine collections during the last 2 days and fasting venous blood samples on days 5 and 6. And here you see the uric acid stone formers in red and the controls in blue. Serum uric acid was significantly higher in uric acid stone formers. Fasting glucose was higher, that was to be expected. Insulin resistance in these subjects was not different, so that was not the problem. The urine pH, of course, was lower in the uric acid stone formers, and the titratable acid was higher in the uric acid stone formers, whereas the NH4 plus was exactly the same. So this was not a problem of insulin resistant NH3 secretion. There was more acid coming out on the exact same diet. What they then did, they took urine and titrated the urine by adding sodium hydroxide until a urine of pH 4. And they had to add more in order to neutralize the pH in the urines of these uric acid stone formers versus the normal controls. So the conclusion was increased hydrogen load to the kidney is as important for the pathogenesis of idiopathic uric acid nephrolithiasis as an inadequate NH4 plus excretion. The identities and sources of the excess acid are diverse and need to be resolved. So far, it has not been resolved. The phenomenon is there. So we have two mechanisms, tubular insulin resistance and an increased acid load kidney independent of diet, which creates a low urine pH as the major driver for uric acid stone formation. How do we treat uric acid stone patients? Symptomatic and preventive measures, mandatory. Of course, it's always wise to reduce meat protein because it's acid rich and additionally lowers urine pH. So exactly as we did in the calcium oxide stone formers, not more than 1 serving per day. Alkalinization is very important because it increases uric acid solubility. Target urine pH is around 6.5 through 24 hours. My patients get fine-graded test strips to monitor that at home. I treat with potassium citrate, or you can also take sodium potassium citrate up to titrate the dose to target pH. The alkalinization, by the way, is able to dissolute pre-existing uric acid stones, but it can take 3 months, but it works. Most of the patients get allopurinol. There's general consensus it is not necessary as long as the patient does not have gout. If you have gout, you need a lifelong allopurinol treatment because the crystals that precipitate in the joints also precipitate in the kidney and damage the kidney function. Now there is a very interesting study again from Texas, Dallas. They're interested very much in uric acid stones. There is primary evidence that pioglitazone, a thiazolidinedione, it promotes the fatty acid uptake and storage in adipose tissue and is the only drug that directly addresses insulin resistance in type 2 diabetes. It's not available in all the countries. They did a randomized pilot study with 36 idiopathic uric acid stone formers, 18 pioglitazone, 18 matching placebo, equal BMI. The adherence check to the patients was done by telephone reminders and outpatients visit, and exactly as before, they had a very precisely structured metabolic diet. What they saw after 24 weeks, insulin resistance was lower, significantly lower in pioglitazone patients. Serum uric acid was more lowered in pioglitazone patients. Urine pH was insignificantly higher in placebo, but significantly increased in pioglitazone patients. And the amount of ammonium coming out per net acid excretion was significantly higher in the pioglitazone. Very busy people in Taiwan read that paper and did a search in their data file and looked at incident stones in non-pioglitazone users versus pioglitazone users and found a significant difference that pioglitazone users had a lower chance of stones than those who were not on pioglitazone. This is a case of my practice, a 52-year-old man, 14 stone episodes, 100% uric acid, fully developed metabolic syndrome, central obesity, arterial hypertension, diabetes, dyslipidemia, as defined by the International Diabetes Federation. I started to correct with his very acidic urine, fasting 4.9 pH, 24-hour 5.07, by giving potassium citrate in increasing doses. The highest dose you always have to give at night, because in the early morning, urine is most acidic. He almost never came above 6.0. Didn't. I gave him additionally to the potassium citrate pioglitazone, and this is a urine pH profile that he's sending. It was more or less always above 6, even above 6.5. So the goal was achieved just by adding pioglitazone. It's not really widely used, but if you take care of single patients, individual targeting of the treatment, then you can use that. Summary: uric acid stones. Behind calcium oxalate stone disease, this is the second most prevalent form of kidney stones. It's mainly a pH disease because the pH is very low. It's a disease of bad genes and affluence, a mixture. Prevalences of uric acid stones increase with increasing BMIs. There is two mechanisms potentially at work: undue urine acidity because of the tubular insulin resistant, or because of the net excretion of not diet-dependent acid. Treatment general measurements is alkali. More specific, you can try pioglitazone. You forget it if it's available. In Switzerland, it's still available, not widely used in diabetes anymore. Kidney stones associated with urinary tract infection stones. 5 to 15% all kidney stones in the Western Hemisphere. That's an old statistic, certainly lower now. The prerequisite is a urinary tract infection with urease-producing bacteria, clinical situations with an increased risk for infection stones, anatomic defects, foreign body, spinal cord injury, neurogenic bladder, vesicoureteral reflux, indwelling catheters, urine diversion, elderly people. The chemistry of urease in human urine. To the left, it's urea. The urease comes and splits that up, and you get H2CO3, and then together you combine with ammonium and get struvite on the one hand, and on the right side you get carbonate apatite. Those are the most frequent crystals that are formed under this regimen. Don't forget the common urinary constituents, calcium, magnesium, and phosphate. They are incorporated crystals and these stones, and we will come back to that in a minute. Now, what are the common urease-producing bacteria? Gram-negative is mainly Proteus, Klebsiella, Pseudomonas, and Serratia. Gram-positive, Corynebacterium, Staphylococcus. And then, of course, the atypical bacteria such as Ureaplasma. E. coli is the most common uropathogen, rarely produces urease, but is frequently associated with kidney stone formation. It increases the calcium phosphate and struvite crystallization induced by urease from other bacteria. If you do that in vitro to a filter sterilized human urine, there's a potential promoting effect of E. coli in urease-induced urinary crystallization. This is an old statistics which shows that Proteus is by far the most common, and then coli, mixed negative, and so on. Now the treatment, it is basically only possible to surgically, urologically treat the patient. Urine acidification has been tried. It increased the solubility of struvite and carbonate apatite. There is a long-term success only if you concomitantly give antibiotics. However, I never would do that because there are many undesired metabolic effects, especially the acidification produces high calciuria, low citraturia, potentially calcium oxalate stones. The long-term administration of antibiotics is only successful with concomitant measures such as surgery or in the old times acidification. It reduces, however, the driving force, lowers the bacterial count by 99%, urease production. Penicillin, ampicillin, and trimethoprim sulfamethoxazole are especially successful against Proteus. And then come the urease inhibitors, hydroxamic acids. They inhibit stone growth in randomized placebo-controlled trials, but are highly toxic. Acetohydroxamic acid is potentially used in the United States, almost never in Switzerland. There are 3 randomized controls tried, all with concomitant antibiotics. No significant difference between the drug and placebo in risk for symptomatic and radiographic stone recurrence, but a significant difference in reducing stone growth rates versus placebo. However, there were inconsistent definitions of stone growth in these studies. Significantly more withdrawals and adverse effects with acetohydroxamic acid is inconsistent reporting. Now, this interesting thing, urease-induced struvite precipitation from human urine in vitro. They took healthy subjects, red is before citrate, and they induced by artificially incubating with urease struvite precipitation. It was quite excessive. And then when they put the subjects for several days on potassium citrate and repeated the study, there was significantly less struvite precipitation. So citrate was able to reduce struvite participation. I keep that saying in all the meetings for many years, but nobody starts to use citrate. And here's the I have already alluded to that. Struvite as well as apatite incorporate very common urinary ions such as calcium, magnesium, and phosphate. And here is where citrate comes in. Citrate is a chelator and will bind in solution calcium as well as magnesium, and thereby there is less of these ions available to precipitate struvite and carbonate apatite. The summary, this is from an Italian review paper. There is a strong association between kidney stone disease and the recurrent urinary tract infection, in numerous studies demonstrated. Surgical clearance of kidney stones usually resulted in the resolution of urinary tract infection, but discordant data persists regarding recurrence. This systematic review clearly shows that urinary tract infection and kidney stone disease are mutually coexisting and reciprocally causal. As such, patients should be counseled for proactive intervention. I think that's the urologist, the only man that can help us here. Cystine stones. It's again about pH. Very important microscopy of the urine. This is the only crystal that directly defines disease. If you see a calcium oxalate crystal, that doesn't mean your patient is a stone patient. If you see this, you have a case of cystine stone disease. Very old data which clearly have shown the higher the pH, the better the solubility of cystine. However, it has to be above 7. Let's say. 1 to 2% of all kidney stones are cystine stones. It's a very complex autosomal recessive genetic disorder with abnormal jejunal and renal transport of dibasic amino acids. You have 3 genetic types, type A, B, and type AB. The worldwide prevalence varies between 1 to 2,500 in Libyan Jews and 1 to 100,000 in Sweden. It is the most common inborn error of metabolism, and many times the stones are heterogeneous because they always incorporate calcium oxalate, phosphate, and struvite. The solubility in urine is, as I alluded to already, strongly pH dependent. At pH 8, you can dissolve 900 to 1200 milligrams per liter. However, at pH 5 to 7, only 300 to 400 millimoles are added. Normal subjects have less than 20 milligrams, heterozygote type B more than 100, and homozygote type A cysteinurics more than 400 milligrams. So they have to increase the urine pH in order to dissolve the cystine. Hydration is the most important, and here you have to go to 3 to 4 liters at least. So the fluid intake probably should be 4 to 5,000 ml per day, regularly distributed throughout 24 hours, so you need a high urine flow. Low salt intake has published even in the New England Journal of Medicine many years ago, but it's poorly tolerated and the effect is not very large. Rigid methionine restriction is poorly tolerated and you get malnutrition risk. Alkalinization is the most important. The goal is to maintain urine pH above 7 to 7.5 throughout 24 hours. You can do that by potassium citrate in very high doses. It's better than sodium bicarbonate because of the fluid overload. Acetazolamide has used to increase urine pH, but you get renal tubular acidosis and thereby calcium phosphate stones and loss of bone mass. I do not recommend that. Treatment with thiols. This is a cystine molecule, and a thiol is able to split the disulfide bridge here and make 2 cysteines. This is cysteine, and this is 50 to 200 times more soluble than cystine. So the idea is basically good. The indication is cystine excretion rates above 20 milligrams per day or 3 millimoles per day. The compounds that we have is D-penicillamine. I never use it. It's effective but high incident of dose-limiting toxicity, fever, rash, proteinuria, lupus erythematosus-like syndrome. More widely used, probably thiopronin. Thiol is equally effective but less toxic, but in my patients still too toxic. Captopril, the kinase inhibitor, there are no controlled trials. It's much better tolerated than the other drugs. Inconsistent clinical results. I try this if high volume and alkalization do not work. in the literature, the busilamine used in rheumatoid arthritis and COVID-19 has serious side effects. They announced the phase 2 trial in stone disease in 2017, but I haven't seen the results yet. New tolvaptan, an arginine vasopressin receptor agonist, increases diuresis, makes sense, decreases the concentration of cysteine, but there are only animal and human pilot studies. But that will come probably. What I wanted to tell you, alkali citrate is a panacea for all stones. Calcium stones lowers urinary supersaturation, inhibits crystallization. Uric acid stones improves solubility if you increase the pH. Infection stones, catheter encrustations, lowers urease-induced crystallization. I have anecdotal experience in a cancer patient. The ureter was totally surrounded by tumor and blocked the urinary flow. And they put in an indwelling catheter. This catheter had to be replaced every 4 to 6 weeks by the urologist. Once they called me, I told them, give them citrate. The catheter lasted for 6 months. So you should try that. Cysteine stones improve the cysteine solubility if you manage to increase pH to 7.5 to 8. The very end, drugs and urinary crystallization, stone formations. This is just a table. There are drugs which alter the urine composition. Of course, carbohydrate inhibitors produce hypocitraturia, ethylene glycol overdose, hyperoxaluria, calcium carbonate overdose, hypercalciuria, D-penicillamine hyperoxaluria. All the others on the right side can be found directly in stones because they crystallize, precipitate. Triamterene is a very old example, sulfadiazine and so on, antibiotics, the quinolones, ampicillin. So you see here the whole list. Medication for HIV patients used to be a topic, but it's not that much used anymore. Indinavir, ritonavir, saquinavir, atazanavir, nelfinavir. Allopurinol can also crystallize, and some analgesics. Summary and conclusions on non-calcium stones. Uric acid lithiasis is the second most common stone disease. It's a pH disease, as uric acid is hardly soluble at low urine pH, with rapid crystallization even at normal uric acid excretion. The main therapeutic goal is alkalinization to pH 6.5. Cysteine stone disease is another pH disease, as cysteine is almost insoluble at normal urine pH. So high doses of alkali are needed for reaching permanent urine pH values above 7.5. Urine volume must be drastically increased to at least 3 liters per day. Available drugs are either not yet sufficiently investigated or have serious side effects. Infection stone disease antibiotics are not the definite cure, but support surgical removal of stones as the effective resolution of the stone problem. Alkali citrate, in my opinion, can be seen as a panacea for all the stone forms that I have presented tonight. And with that, this is the very end of my presentation, and I thank you for your attention. Questions, comments, personal experience, better solutions?
How many nephrologists do we have here? Raise hands. Best? Dala. Come on. Oh. How many urologists?
Wow.
Okay.
Congratulations.
Thank you very much, Professor Hess, for this wonderful lecture. Stone disease is a common problem in Kuwait. Nearly 50% of our admission to the hospitals are stone diseases. And usually the urologist, they treat them surgically or conservatively and send them home without going deep and investigate patient thoroughly. Now, my question, for example, I got a patient with renal pelvic stone with 2 centimeters 2 years back. We have cleared him totally by percutaneous approach. He came again this year with the same size of stone, although he has normal blood and urine test. So what's your precise indications to say this a patient should be investigated thoroughly, blood and urine test, or other patient just to give him treatment and send him home?
Thank you for the question. As I told you, a first-time stone former, we do not automatically do all these tests, except if the first stone is a 2-centimeter stone. I would wonder, what is the stone analysis? Is it an infection stone? Or is it a cystine stone? I would do some tests. But otherwise, we would tell the patients to drink 3 to 4 liters, in your country possibly 5 liters a day, and go home. And if he comes back, then we would start the whole workup. With the first time, it's not necessary, but with the second or third or fourth, always.
This is your indication.
That's what we are doing, yes, and I think that's general consensus worldwide.
Or you debate on the analysis of the stones?
Not only, no. I think if you have a second stone, I would go over all of the things. Of course, I'm interested in the stone analysis, but I would do it anyway. And I think you are here about to get an interdisciplinary setup, Yusuf, and I think we can profit from that.
Dr. Ahmed, maybe want to tell us a bit more about the interdisciplinary efforts?
Yeah, thank you, Dr. Yusuf. Actually, by the initiative of the nephrology in Mubarak with the lead of Dr. Yusuf and Dr. Mu'min, we took the initiative to starting the establishing stone clinic in Kuwait. So also we've been enlightened by the Professor Hess' visit to discuss more. So hopefully we will announce soon the coming months, once we have all the infrastructures and the needed resources. With Dr. Yusuf, the stone clinic will start as initiative will be like for Hawali catchment area. Once we have the flow, then we will extend it to the whole Kuwait. Just wait for the announcement, and hopefully that you refer patient, and for the maximum benefit for the whole community from nephrology and urology with MDT clinic, where will be a urologist and nephrologist and dietitian, along with the help of biochemistry lab and the stone analysis. Thank you.
Any more questions? Okay.
Everybody is tired.
Yeah. And hungry.
Hungry.
So
Okay.
please, you are all invited to the dinner, the main hall. Thank you, Dr. Hess, for the
Thank
good
you.
talk, and it was a pleasure having you with us.